Good morning, everybody. My name is John Maynard, Product Manager for Shield Healthcare. Welcome to our webinar titled Pressure Injuries, Choosing the Right Treatment. Your presenter today is Nancy Morgan, co-founder of the Wound Care Education Institute. Attendees will be in a listen-only mode. If you have a question for Nancy, please type it into the question box to the right side of your screen. There are also handouts you can download. At the end of the webinar, we will show you how to receive CE credits. You are all qualified to receive 1 CE credit. And again, we'll show you how to do it. At this time, I'd like to present Nancy Morgan. Nancy is a founding partner of the Wound Care Education Institute. She has been a WOCN for more than 20 years, and she's board certified in wound, ostomy, and diabetic wound. Nancy is a nursing entrepreneur with an MBA. She's a dynamic speaker and international presenter who still conducts much of the hands-on training in wound care education for WCEI. Her motivational teaching style has inspired healthcare professionals across the nation. It was Nancy's entrepreneurial spirit that led her to co-create the Wound Care Education Institute. Without further ado, I'd like to pass the presentation over to Nancy.
Hey, thanks, John, and thanks, Shield Healthcare, for making this happen. Appreciate it. A little bit about my day job, for those of you that don't know me. I'm one of the co-founders of the Wound Care Education Institute, and it's founded by 2 women, 2 nurses with one idea, and that is to improve management of wound care patients all across the United States. And we support about 30,000 alumni nationwide. So we have the WCC course, that's what I've got on my shirt, Wound Care Certified. It's for doctors, nurses, and therapists. And then we also have a diabetic wound certification course. And then lastly, we have an ostomy management certification course. So that's what our day jobs are. I do want to point out, in the question box, as you guys are kind of chattering and posting back and forth, we do have Donna live with us. And you'll identify her as Donna WCEI. And she'll probably write in caps. So in case there's anything that needs to be clarified during this webinar, she's got your back. She'll be there to back you up and answer any questions that you might have. Also, for those of you that we also do a national convention, and it's called Wild on Wounds, and I'll be honest with you, it is exactly what it sounds. It's walk and talk and wound care 24/7, 3 days. Shield Healthcare is going to be there as well to support us, and this is where we do a lot of hands-on labs. We love getting our hands in things, learning how to compress lower extremities correctly, doing a sharp debridement lab. We also have a maggot lab if you're into that, but this is where we meet all the industry experts that teach us about wound care and different products. So everybody that's on the line today are welcome to come and join us at Wild on Wounds, August 31st through September 3rd at the Rio Hotel at Las Vegas. So let's get started with the webinar. And what we're going to do is we're going to talk about pressure injuries, which that is just a new name that just changed as of April 13th. It used to be called pressure ulcers, but it is now changed to pressure injuries. And we're going to focus today on choosing the right treatment for these pressure injuries. So how do we know what we're doing is right? Well, we need to follow the standards of care, okay, and we need to be current and updated. And we also need to make sure that we are following this wound carefully so it's progressing like it's supposed to be through the phases of wound healing. We need to have an individualized, customized care plan for each patient. And we also need to just stay away from cookbook medicine. Y'all know what that means. Sometimes we see clinicians saying, a little bit of this and a little bit of that smeared on their buttocks, that's going to heal. And they're making up their own magic potions and lotions. And we really need to kind of stay away from that cookbook type medicine. Whatever product we pick up, we got to make sure we're following those manufacturer's directions and that it's FDA approved for wounds and for humans too. So what's the first step? We have to assess. And that means we need to jump inside this wound, everybody, and we need to identify what the tissue and structures that are lying before our eyes. Is it eschar? Is it slough? Is it granulation? What are we looking at? Is it dry? Is there drainage? If so, how much? Does it have an odor? We've got to get a good picture of what's happening in this wound. And also, what is the size of the wound? And where is this wound located? Because that all kind of helps us figure out what best treatment to use for this patient. Also, we need to look at the family, and here's a picture of a family, large family, and look at the patient's what are the goals of care for the individual that has the wound, but also the family? What's their health history like? Are there any factors that we're going to come up against that's going to slow healing, stall healing, such as patients not getting enough oxygen, they have sensation issues, they have an active infection going on, or they just don't have good circulation? If they don't have good circulation, that means I'm not going to have good blood flow, and there's just no way I'm going to be able to heal a wound with no blood flow. So we kind of look for those things too. Also, part of our assessment is to make sure that any patient that's coming through your door that has a wound from knee below, I want you to do a vascular assessment and see what they're doing there in that picture. That's an ABI, and it stands for ankle brachial index, and that's something that we all need to be doing on every single wound that's walking through the door, patient that has that walking through the door that's knee down. We need to make sure what exactly type of wound are we dealing with. Is it a pressure ulcer? Is it a venous leg ulcer, arterial, or maybe it's venous and arterial mixed? Once we know from the get-go, then we can get a care plan in place in order to get these wounds to heal and wipe out these wounds. We need to also make sure that we have updated laboratory tests and make sure their nutrition is where it needs to be. And I know you all do risk assessment tools, okay? We need to make sure that we have that in place. And we have to do that now with the new guidelines that are out within 8 hours of admission. And it doesn't matter where you work, home care, long-term care, or hospital, within 8 hours. We have to do it and we have to document on it. We also have to pull in that pain assessment. What kind of pain are they dealing with? Now this guy right here, he's got pain before she's even sticking him with the needle. Well, we need to know about that and look at their body language and different nonverbal cues that they might exhibit. Social and financial support systems, we need to look at that. Environment, where is this patient going to live? Right here, here's a home care setting. Who's taking care of that patient? All these are different considerations we need to take in consideration and make sure that we're writing the right care plan. What's that patient's knowledge of pressure injuries? What do they know about that? Do they know how bad these can get? The best way to solve any problem, everyone, is to remove the cause. One of the first questions we always say at the Institute to all our students that you've got to ask yourself when you encounter that wound for the first time is what caused that wound. Today's webinar is on pressure ulcers, okay, pressure injuries. Well, that's caused by pressure. Well, then we need to do whatever we can to remove that pressure and offload that site. We've got to remove that cause. Because this is what happens. See, you see a cut section of the skin, you have pressure that's compressing the tissues down, and what it does, it chokes off the blood supply. And when you don't have any blood supply, over time, that tissue is going to die, become necrotic, and then we've got problems. So we've got, once we figured out this is caused by pressure, let's remove that pressure immediately. It doesn't matter what product you have on that site, that wound is not going to heal. You've got to remove the cause. That's very important. So how to remove the pressure? We remove them by positioning them, turning them, and this is all based on the patient's, what's going on with that patient. Individualizing these turning and reposition schedules. What's their tissue tolerance level? Activity and mobility status. What is the overall treatment objectives that we have? What's their skin condition? And what kind of support service do they have in place? Is it adequate? Is it going to do its job? We need to avoid skin-to-skin contact. So make sure that when we are turning a patient, repositioning our patients, we're using pillows, we're using foam wedges to avoid these bony prominences from knocking together. Also, when we're turning our patients, a good rule to kind of remember, because this is kind of catchy, it's called the rule of 30. So what that means is the head of the bed is elevated for no more than 30 degrees. That includes your tube-feeding patients. And then when you turn them to the side, you want to turn them just 30 degrees laterally. Make sure their shoulders and their hips are tilted at 30 degrees as well. So it's 30, 30, 30. When we are moving these patients and transferring these patients, we're using lift sheets most of the time, right? And then we also have different slings that we'll use. We'll definitely use these lift sheets, and then when you're using a sling, okay, for a mechanical lift, it's suggested to use a split leg sling. And that's important. Otherwise, look at this. Now, sometimes we have people that are just sitting on the same sling, and that clinician should have removed it as soon as they put that patient in the chair or in the bed. But they left the sling underneath this patient, and look at the skin, how it broke down. You can tell the wrinkling of where the sling was. We can totally avoid this by making sure that we're following the manufacturer's instructions. And hey, if that sling needs to be removed, let's remove it. Okay. Also, when we're choosing beds with an auto contour feature, and what that means is what you see on this slide here. You put the head of the bed up by pushing a button, the head goes up, and then also the knees go up. You probably see that a lot in electric beds, and that's called auto contouring. And that's actually an intervention to decrease the friction and shearing forces on your patient's skin by having beds that provide this feature. If you have the crank beds, do you guys have crank beds still? Do you see them? I remember them. Back in the day, that's all the beds were like that when I first started out nursing. So, okay, if you're stuck with the crank bed, you want to crank up the knee first, and then you crank up the head. And then that way it'll prevent them from sliding down. It's called knee gashing. Also, make sure you put some type of wedges under the patient's arms or pillows so they're bolstered up and in proper position. We never want to put a patient directly on an ulcer, okay? And as you see here, we have multiple turning surfaces that are involved here on this patient's body. So we need to make sure that we're avoiding these areas. And in this case, this person definitely needs a special bed. So what are they saying about heel pressure injuries? Well, what they're saying to us is stage 1 and stage 2, they want us to float the heel. See how they're doing in this picture here? They floated the heel, they're using that wedge, and they're covering that whole calf area, okay? But there's nothing touching the heel, and that's exactly where we want to be here, floating the heel. Also, you can float the heel. If you don't have these wedges, then you can also use a heel suspension device, which I have a picture of that coming up. What the guidelines are saying, and when I say the guidelines, I'm referencing the International Pressure Ulcer Guidelines that were released fall of 2014. And in there, they said stage 3, 4, and unstageable wounds, okay? Pressure ulcers, pressure injuries, use device that elevates the heel from the surface. They want you to use a heel suspension device. This is just an example of what you see on this photo. Every manufacturer has their own. So kind of look at this peekaboo hole here, how they have it cut out. Notice there's nothing touching the heel. This particular one is held on by Velcro straps. That's fine. And it has it can expand or actually get smaller, so either way. But it also is not putting extra load on the Achilles tendon. That's what we want. We don't want to put a lot of pressure on the Achilles tendon because it doesn't have much blood flow. Put a lot of pressure, it's going to break down. We don't want that to happen. So we want to utilize that whole surface, and that's what they're doing in this particular one. What the guidelines say, and I need to drive this home to you, pillows alone are not adequate. So what does that mean to us? Oh my goodness, everybody in the world is using pillows to float heels in America. I know. Well, they wrote it in the book, fall of 2014. You know what happens when they write things in guidelines and they write things in books. They're going to take that book and they're going to measure us in the court of law. So get rid of those pillows. Pillows are for short-term use only, but if you have a full-thickness wound, stage 3, 4, unstageable, forget about the pillow. Don't even go there, because I've seen homes getting cited for that. And just invest in one of these, okay? Now, I'll be honest with you. There's lots of manufacturers that carry different ones. Test drive them. Trial them out. One is not going to fit all your patients. You're going to need several different heel suspension devices to make it work in your facility. But make sure you have one of these in place. Also, when you pick the right heel device, whatever it is, make sure it's not too tight. Look at this picture. Notice, it was too tight. It caused pressure ulcers, and I know it's pressure ulcers because pressure ulcers tend to be circular oval. See that? And this is full thickness. This is down to now we have necrotic tissue. This is inappropriate fit. So whatever we're putting on our patients, they're considered medical devices. We got to make sure that they're properly fitted. Remove that device. Look underneath the device. Make sure that skin's not breaking down. So what I did here in this slide, you see the heel offloading devices, okay? heel suspension devices that will be on the left side of your screen, and then the other items that we might see in healthcare are on the right. Well, the ones on the right are actually just kind of padding. It provides it might decrease friction forces on the skin. However, it's not truly offloading. So what we need to do is we need to get items that are on the left side of that screen. True heel suspension devices. Nothing touching the heel. What are they saying about folks that are seated? Well, if the patient has upper body mobility and they can kind of, move themselves, we'll shift the weight every 15 minutes. That's what we want to encourage them to do. But if they're unable to shift their weight themselves, well, we need to do it for them. So we need to reposition that patient every hour. And when we're looking for different wheelchair cushions, for these patients that are, sitting in the chair-bound type patients, well, make sure that we have a good one. It's not that cheap, floppy one that's deflated, or, I've seen these foam ones. They're just flat, and then when you touch it, it just kind of crumbles because it's so old. These all have lifespans. Either some last 6 months, some could last a year or whatever. So make sure you get a really good wheelchair cushion in place to support your patient. And your goal is to evenly distribute the weight over this wheelchair cushion. And make sure, see that cover? I want you to make sure that it's stretchable and breathable. Very important, okay? You need those two things, and this is coming out of the guidelines here. They want it stretchable so it moves as the patient moves on the surface. And breathable, well, you all know why we would want it breathable, right? Yeah. Okay, so what are they saying with folks that have a pressure injury when they're seated? Well, the rule's still the same. Nothing's changed with that. When seated and they have a sacral, coccygeal, ischial type ulcer, pressure injury, they can get up 3 times a day, but no longer than 1 hour max, okay? They want us to consult a seating specialist. You all know who that is? Now, I want you to know I can read what you're typing to me. Okay, so what a seating specialist is somebody that's very important in our wound care team, and that is the PT, physical therapist. And from what I understand, occupational therapists can help out too. So we don't want to leave them behind either. They're vital, part of our wound care team. Get our folks in there to make sure that those patients are seated properly, that the seat is so far above, above the ground. We want to make sure it's a certain height. We want to make sure there's enough space from the patient's body to the side arms. We want to make sure, because how many times have you seen a patient that's in like this large wheelchair, and then the patient's just kind of moving around, you got all this friction going on? Or you have a big size patient, okay, in a small little chair, and they're stuck in that chair and they're sitting like a sausage. That's horrible. You know what's going to happen is they're going to end up breaking down on their trochanters, and that's not good. So we want to make sure that it's properly fitted for that patient. We're going to talk about support surfaces, and this is very important because, okay, we're talking about pressure injuries, and it's caused by pressure. And a lot of these folks get pressure injuries because they have immobility. They're chair fast, they're bed fast. We got to make sure we're covering our bases. So we got to pull in the support surface factor here and here on this one. So what they're saying here is, and you have details in your handout. And those of you that don't have handouts, you can always click the link. It's in your little dashboard there and get the handout. But what they're saying for patients that are at risk, use a high reactive foam mattress like you see here on the screen. Okay? This is what the industry is going to. These have a longer lifespan. These last a while. Many of them have a special cover on it that's like an anti-shear liner on it to decrease friction and shearing forces on your patient's skin. So this is what they want under our at-risk patients. When I say at-risk, these are at-risk patients for pressure injury development. They also use an active support surface for high-risk patients. Okay. Well, how do I know if they're high risk? Well, within 8 hours of admission, we've got to be doing that Braden scale or whatever risk scale that you guys do there. We got to do it, and that's going to tell us right away if that patient's high, moderate, or low risk. If they're high risk, we got to get one of these under them, and that's called an active support surface. And what that means is, well, if I say alternating pressure, you guys probably know what that is. one of the cells go down while the other one goes up, and it'll wait a few seconds or a minute, and then it'll shift back. Okay. The coverings on these also have this slippery type material. It's kind of like a parachute feel to it, and that's to decrease your friction and shearing forces on the patient's skin. Every manufacturer has these types of devices that you can use. This one, I get tickled on these because I still see these in healthcare. Do you guys see these in healthcare? We are not supposed to use these things. Donut rings. I know it's not usually healthcare folks that are bringing this in. It's usually the families of the patients, but got to get them out of the door. They're not therapeutic. It's not going to help our patients. Taking rubber gloves and filling it with water is not going to do anything for us. Synthetic sheepskin pads, out the door. And this one here, in that upper right corner, see that IV bag underneath the Achilles tendon? Remember what I told you about Achilles tendon? Doesn't have a lot of blood flow. Well, that's where they put that there. Well, you know, that was at a hospital. I won't even name the state, but this was not too long ago, and this is how they floated heels in that hospital. And you know what? This was one of my students, and her mother had hip surgery, and so this is how they floated her mother's heel. Well, she took a picture, and of course I had patient consent, and I gave them a call because this is terrible. And you know what they were doing? They were charging the patient for the IV bag. Yeah. And then they would reuse those IV bags. Anyway, TMI, right? I know. Well, anyway, so we made a same phone call, and we got some education over there. They're not using these IV bags anymore. But these kinds of things, let's just take them out the door. They also say in the guidelines to make sure that if you're using a mattress, you know, small cell, less than 1 inch, alternating air mattress or overlay, we don't want to use this, okay? Less than 1 inch, think about it. It's like, it's not going to do anything. You know, we want to make sure that we are evenly distributing that patient's weight over this surface. And this, to me, is just kind of like one of those rafts you can float around in the swimming pool with, right? No therapeutic value. So let's stay away from these types of overlays, mattresses that are less than 1 inch. Let's go into mattresses like this. Okay, we've got good foam, high density foam. Some of these mattresses have heel sections. Some are just foam. Some are, you know, foam, non-powered type support surfaces, and they were going to last you much longer. They're saying in the guidelines for stage 3, 4, unstageable and DTI pressure injuries, make sure you have one of these. And this is, you know, this is upgrading our mattresses here. Low airlock mattress, continuous low type mattress, air fluidized therapy, alternating air therapy. So these types of devices is what they want under a patient. Now we're on to the topical treatment plans. This is what everybody wants to hear, you know. And so what we do and then what we have in this section is we're just going to break it down, and we're going to break down the flow to where, you know, what are you going to do for stage 1? What are you going to do for stage 2? So I'm going to kind of take my time through this and make sure that we have this. We have to have all the offloading in place and all that I talked about earlier, but now we're just going to focus in on what are we going to put on this actual wound. Now, as you see in this picture, this is a hydrocolloid, and they cut it in pieces. And then notice they overlapped it on each other, and that is just not the right thing to do. So if you find you have to do this, you got the wrong product. And I'm going to just, we'll navigate through this section together. Before you guys pick up that product, I want you to consider some factors. Number 1, you already should have done a wound assessment, identifying the tissue type, the size, where it's located, and also one thing I didn't mention is I want you to include that peri-wound space. And what peri-wound space is, look at this picture here. Yeah, we're going to measure that wound, open edge to open edge, and we're going to assess that open wound. But we're also going to jump outside that wound. And what we want to include is 4 centimeters of peri-wound tissue. Okay? So if it has erythema or yeast or whatever, we want to pull that in. We want to factor that in. So we want to include that peri-wound space. We also want to consider, you know, what's the patient's goals? What is the purpose of the treatment? How often do we do this? And I understand there's a lot of folks from home care here on the line today. You know, and hey, I get it. You can't be going there every day changing patients' dressing. So, You know, how often are you visits going to be? If it's only going to be 2 times, 3 times a week, well, then we need to choose a product that's going to extend the wear time until you come back. So those are some things we need to consider before picking up that product. Just to review, before I go into topical therapy, okay, before I go into all these dressings, because I'm going to say a lot of stage 1, 2, 3, 4, I just want to make sure we're on the right page. So stage 1, and this is not, I'm not doing the whole 100-word definition here, but I just kind of want to bring it up to your radar. Stage 1, 3 things pretty much is key: intact, red, and non-blanchable. That's pretty much it. So on dark skin, see that top picture? We don't want to miss that stage 1. So when you see that affected site, I want you to look at that surrounding tissue, and I want you to compare it visually, but I also want you to put your fingertips on it. We cannot rely visually on dark skin. I want you to palpate that tissue, and there you'd find out a lot of differences. Is it soft? Is it boggy? Is it warm? Is it cooler? These are key things that'll tell you, hey, you know what? I think I do have something here in this area that we need to offload, we need to be proactive on. So that's stage 1. Stage 2, okay? Think of the 3 Ps, okay? This is just the way I keep it straight in my head. 3 Ps. Pink, it's partial and painful. So this is partial thickness skin loss. So epidermis is missing. You have destruction in the dermis, but you're not through it. So you're pink, you're partial, and you're painful. And then I'm going to add one more thing here on this. See that picture of the blister on the heel? Okay. Serum-filled blister, call it a stage 2. Okay. Now, when you see a blister, I want you to look inside that fluid, get your pen light out, and shine it right in there. If you can't see very good, if it's 100% clear, fine, call it a stage 2. If you get anything that might be brown in there, discoloration of the fluid, well, that's blood. There's nothing else in there that would cause that discoloration, so it's blood, and then that would be a DTI. Okay? But if it's clear, like in this case, we'll call it a stage 2. Stage 3, okay, peel off the epidermis, take off the dermis, you're in the sub-Q, and that's as far as you're at. You're not any further down. So with this case, let's look at these pictures. You jump inside the wound and you see granulation tissue, and you see yellow slough. And then just to double check ourselves, do we see muscle, bone, or tendon or anything like that? No. And then I want you to take your gloved fingers and I want you to palpate that wound bed. Do you feel it? Muscle, bone, tendon, ligament, anything like that? No? Okay, then fine. If not, it's just solid tissue, it's a stage 3. But if you feel bone, muscle, tendon on palpation, you take it all the way to stage 4. Okay? So just kind of making sure that we're on the right page. And this is all embanked into the definition. Stage 4, we can see muscle, bone, tendon, cartilage, bone. They made a big list here. But we can also palpate, okay? Either we could see it, or we could palpate, or we can both. So here we have that picture on top. And it has a lot of junk in it, right? Slough and necrotic tissue and all this stuff. What I want you to do when you see wounds like that is I want you to go on the hunt. That means jump inside that wound and, you know what, move the tissue around, probe around with your applicators. See what you're feeling. Are you feeling bone? Are you dragging it across bone? Is that a muscle? Now in this case, visually, I see muscle. Boom, I'm at a stage 4 right away. But I want you to make sure, go on the hunt. See if it's there. Here's the one on the bottom. Well, what do you guys see there looking right at you, right? You probably can knock on it. I mean, that's bone sticking right out at us. So, yeah, and that's hard. Hard bone. Okay, here we have DTI. Remember, it used to be called SDTI, suspected DTI. They got rid of the suspected word. It's now straight up DTI. I do want to drive this one key thing to you, and that is DTI is still non-blanchable. It's non-blanchable, but it's intact, but they also included non-intact. And what that means is, look at the second picture on the screen. Notice the epidermis. It must have been a blister, but the epidermis is removed, okay, exposing the dermis. That's what they mean when they say non-intact. This doesn't mean that it opened down to the sub-Q, okay? This just means that the epidermis has separated from the dermis. So a DTI now can be intact or non-intact. The colors are pretty much the same. It could be deep red, maroon, purple discoloration. And of course, on dark skin, as we talked about earlier, we don't want to miss anything. So we're going to look at the affected area. We're going to check the surrounding tissue. We're going to check visually, but we're also going to palpate that tissue so we're not missing anything. And then lastly, we have unstageable. And unstageable pretty much remain the same since they changed the definitions. It's still full thickness, and it could be covered with slough, or it could be covered with eschar, or it could be covered with both. Okay. Right now it's covered, and we even tried to palpate on it. We can't feel anything. And so what we're going to do is we're going to call it unstageable. So that would be unstageable. So that's pretty much my quick review on staging before we get into these topical treatments. Some basic guidelines, okay? What we want to do is we want to choose a dressing to keep that wound bed moist. I don't know if you hear clinicians say, rip off that dressing, rip off the sheet and let the wound breathe. You ever hear people say that? Well, we need to remind them that that wound bed does not have lung tissue. They don't have to breathe. If we keep it moist, that wound's going to heal 2 times faster in the presence of moisture, and that's where we've got to go, ladies and gentlemen. That's where we have to go. So we want to make sure this thing is going to keep moist. We've got to clean those wounds every time we change that dressing. By cleaning those wounds, we get rid of all that surface junk that sits there overnight, and then we can have a better assessment when we're looking at it visually, get rid of that surface bacteria, because we don't want to miss a beat when we're doing our assessments. So what can we clean the wounds with? Well, you could use simple, normal saline, okay? Also, if you happen to be in the Mojave Desert and you have nothing on you other than drinking water, as long as you can drink it, then you can put it in a wound. That's what the guidelines are saying. Actually, this doesn't look too bad right now. I was getting a little dry. All right. You can also use wound cleansers that are non-cytotoxic. Some other basic guidelines to think about is whatever you're picking up, either it be an ointment, a dressing, a foam dressing, a collagen, or negative pressure, take a few minutes and make sure you're following the manufacturer's guidelines, their recommendations. We have to follow that as a T. Prescribing authority, different story. Nursing, therapists that are on the line today, we've got to follow those instructions. In the court of law, that's what's going to protect us, so we got to follow it to a T. We want to stay on label, not off label. And I want you all legally, defensible at bedside. So take a few minutes, read those instructions. Also, another thing to keep in mind, and I have seen this in the field. I'll be honest with you, I get frustrated. I will see an account have, let's just say, for instance, Silvadene twice a day for the last 8 months with no improvement. Those kinds of things, those treatments are out the door. Those are not acceptable. We cannot do that anymore. What they want us to do is, hey, we got to see improvement, and we have 2 weeks to make it happen. So at the end of 2 weeks, we don't see anything positive. Wound edges aren't shrinking down. The measurements aren't shrinking down. Exudate hasn't decreased. If we have nothing positive happening in 2 weeks, we got to change. We got to update that treatment, change that dressing. And that includes not only the dressing, but also we got to upgrade the support surface too. Because, we got to offload the pressure, so we got to make sure that we've got the whole picture upgraded. So 2 weeks, 2 weeks, 2 weeks. That's kind of the big rule here that we do in wound care. No progression, nothing positive, let's change it. Let's try something else. If you're trying a new product, give it 2 weeks. Don't do it for 4 days and stop, because that's really not going to give the product a chance to show proof to you. So you really want to test drive it for 2 weeks. Okay, what are they saying about stable eschar on the heel? Well, this is what they're saying. See the top one? It's called stable. It is dry and capped. And when you take 2 fingers right on top of that cap and you rock it back and forth and it's solid, then that's considered stable. There's nothing oozing out of it. There's no signs and symptoms of infection. That's called stable. And that also means that there's no fluctuance. Sometimes, like on the bottom one, you could take your fingers on the top and rock it back and forth, and you feel like this ushy-gushy movement, oozing of drainage that you might see. That's positive for fluctuance. Now, that's a fancy word for what that means. Now, make sure that whatever you do, that you don't mess up the word fluctuance with flatulence, okay? Because those are 2 separate definitions. I've just seen people do it, so we just want to be on the right page. But on this case, we have dry, stable eschar. We just keep an eye on it every day. You can paint it with Bandaids, alcohol swab. But, you know, like on the bottom one, it's unstable. Bacteria is harboring in that necrotic tissue. We need to get this off immediately. Time is of the essence. We also can get a vascular consult and get that on board. I mean, this is time sensitive, the unstable eschar on the heel. So here we go, like I said earlier, Bandaids. You can also do non-sting barrier films right on the eschar cap. That would be good. You can choose to put a dry dressing in place if you'd like to for protection. Some people will just leave it open to air. That is okay too. There's nothing wrong with that. I just want to make sure that someone's watching this every day. We don't want this to turn and become unstable. Here's a situation where we have unstable necrotic tissue. And in this one, it's full thickness and we've got yellow slough. Well, if our goal is to heal, we got to get rid of that junk that's in there, which is that yellow slough, because it's in our way. So here's some different topical treatments that we can do. And it's a long list. So it could be a hydrocolloid. In this case, we would fill the dead space with something first and then put a hydrocolloid on top. We could do a transparent dressing, even foam dressings, impregnated gauze, or even Silicone. And that's a sterile enzymatic debriding ointment that we would do every day. So those are some things that we would do for unstable necrotic tissue. Don't forget about the adjunctive therapies that we can pull in too, because this is just going to speed things up for us. You know, sharp debridement, and that's what they're doing there on the picture. Pulse lavage, hydrotherapy, electrical stim, or see that jar? It's full of maggots. Yeah, medical maggots, by the way. Yeah, medical maggots. They're bought from a lab, and you can put them in there, and they will just kind of liquefy that necrotic tissue, and at the same time they do that, they're going to stimulate fibroblasts to grow too. And so you kind of got the two-in-one action going on by utilizing that type of therapy. So you can think of these therapies that are adjunctive therapies that can complement the topical treatments that you're doing as well. Okay, so I've got a stage 1 pressure injury. What am I going to do about this? Well, number one, we got to remove the cause, okay? Definitely. Remove the cause, offload. And we don't want to massage these areas. Years ago, that was a rule, but we don't do it anymore. We found out that we were actually hurting the tissue that way. So here's some different topical treatments that we can put in place. Transparent dressing, like you see what they're doing with the heel. You could use a hydrocolloid dressing, a liquid barrier film, or even just a thin foam. Okay? Now, I will say, you know, some people may not put anything on that stage 1, and that's okay too. But then some like that extra protection, which is not a bad idea, because like in this heel, you know, Miss Sally kept doing this with her heel on the sheet, and it was causing the stage 1. Well, you know what? Let's put a transparent dressing in place to protect Miss Sally's skin, just to give you an idea. Here's stage 2 through 4 pressure injury that has a dry wound bed. So when it's dry, see this picture? When it's bone dry like that, we got to get this moist, because in order to heal 2 times faster, it's going to heal 2 times faster in the presence of moisture. So what can we do to give this wound a drink of water? Well, hydrogel will do it. You know, putting hydrogel in there. You can also use a foam dressing, because foam and even hydrocolloids and transparent, they will seal down on all 4 sides of this wound, and then it'll kind of trap moisture in there. And over time, it'll moisten that up. And then that way we can start seeing healing. So any of these types of treatments that you see on the screen are fine. Let's see, we've got stage 3, 4 pressure injury with slough, and we also have drainage. Okay, now that drainage, that's a different thing. Now, okay, well, number one, when you see a lot of drainage, we always tell our students, you know, you've got to figure out what caused that drainage. That's just not a normal thing. That drainage is caused by maybe you've got an abscess, maybe there's some edema, maybe you've got a whole bunch of bacteria harboring in that necrotic tissue. Something's causing all this drainage. We need to figure out what the cause is. And hey, like in this case, if it's necrotic tissue, well, let's get this stuff off ASAP. Either we're going to sharp debride it, we're going to use products, we got to get rid of this. So I do want you to question that. When you see, exudate, high levels of exudate, what's going on here? What can we do to change this around? And if it's got a lot of exudate, a lot of times if the product's not good, the exudate's going to spill on the edges in that peri-wound space, tissue. And so we need to protect that. And you can protect that by using skin prep. You can use a protective ointment, a moisture barrier, but definitely be very generous on that peri-wound skin and put it on there so that way that drainage is not going to break down that skin. Okay, so what are we going to do when we have stage 3 or 4 slough with exudate? So we're still on that, but we've got moderate to heavy. Uh-oh, now we got a whole bunch going on. Well, this is where we got to upgrade our product. So that's where we're going to use calcium alginate dressings. You can also use hydrofiber dressings, and hydrofiber dressings are above your calcium alginate dressings. Hydrofiber example on the dressing would be the lower right corner, so that's Aquacel Extra, right? Okay, so this actually, I call these types of products, they're very sophisticated, and they're made from specialized material, and their goal is to really just absorb as much type of drainage as they possibly can. And they also, this particular one also decreases maceration. So notice that 2x2 that you see, it only gets wet where the wetness comes in contact with it. It stops right there. You see that dry line right there? It just stops. Yeah. Now when we use alginate, a little corner of the alginate can get wet, but then it'll pull the wetness right through it. So it depends on what you need. But if you've got a lot of heavy exudate coming out, consider using a hydrofiber, definitely. Also, oops, let me just back that up. Wound drainage collector, I forgot about that. If you have about 45 cc's of drainage coming out of the wound, I want you to maybe consider these types of collectors. And it kind of looks like an ostomy pouch, right? But this is not for ostomies. This is specifically for wound drainage collecting. And see that little window? It's a circular window. You can kind of swing it open. It's kind of like a Tupperware seal. Swing it open, you can manipulate the wound, look at the wound, and then you can close it back, and then the drainage will just drain right through that spigot. And we'll do that for any drainage that's kicking out more than 45 cc's a day. Okay, now we have a stage 2 pressure injury with a red base and a light to moderate exudate amount. Foam dressing, perfect product for this. I'll tell you why. It's because, you know what, these are products that we're talking about that you can put on Monday and many times you can keep in place for an extended period of time. That's where we want to be when we're choosing advanced wound care dressings. And foam, polymeric dressing, membrane foam, these are foams that'll extend your wear time. So always read the manufacturer's directions, but some of these can be in place from 3 to 5, even some 7 days. So take a look at that. The polymeric membrane foam has a leave-behind surfactant that's built into the foam. And that particular one says you don't even have to clean it. So you can take the old foam off, put a new foam on, and you're good to go. Here we have moderate to heavy exudate. So here's just an example of calcium alginate. If you were to touch it, it feels like cotton. It's fluffy, and it's available in a flat or rope, as you see, flat pad or rope. This is made out of seaweed, and sometimes clinicians will call me, oh, I pulled the rope out, but I think I left a few fibers in the wound bed. Is that going to be okay? Well, try to clean it out the best you can and irrigate it, and if you did leave a few fibers, well, and you didn't know about it, well, that's okay. It'll biodegrade into the wound bed. It's all right because it's made out of seaweed, and it's natural. Calcium alginate will absorb up to about 20 times its weight, and we would change this once a day to maybe every other day. And here's Aquacel Extra, and we talked about this. This will, like I said, it's above the calcium alginate. This will absorb up to 33% more than the alginate. So, you know, home care nurses out there, you can't visit that patient that often. Maybe you're only coming in a few days a week. You probably want to play in this type of category and go with the more advanced type product that can accommodate for that amount of drainage. So, we have Aquacel, and when you see AG behind the name, AG is silver. So what that means is, well, you got heavy exudate. You must have heavy exudate for some reason, right? Maybe you have a bacterial load in it. So the AG, the silver, will be inside the wound bed, so it'll help decrease the bioburden. That's what the AG will do for you. Okay, another thing that we can do with a clean wound with a lot of exudate is we could use negative pressure. And there's different kinds out there on the market. Just make sure that you're matching the right one with the wound type. So you could use that. And then you can also use those wound drainage collectors I talked about as well. We also have specialty absorbative dressings, and this, Aquacel, we talked about Aquacel. Aquacel is going to fit in this category, specialty absorbative dressings. These are dressings highly sophisticated. The one that you see here on the screen on your right side, that's Extrasorb. That actually has the ability to take away the exudate from the wound and also lock it inside itself. So it's going to decrease the whole maceration that the wound might be getting with other products. And the large pad itself can take up to about 550 cc's of exudate. That's a lot, right? Home care people in the house, that's a lot. So if you think about it, depending on how much drainage, you could put it on Monday, but maybe you might be able to buy enough time until you come back on Friday, depending on your visit. So these are just good options to just extend that wear time for you. The smaller pad, I believe, is about 450 cc's that it'll absorb. And then you also have a product from Smith & Nephew called Exudry. And Exudry comes in lots of different shapes and sizes, and even in sheets. So it's depending on what body part that you're trying to keep this in place at. They're all different shapes and sizes, and another good product that can take up a lot of exudate. For fragile tissue, what are we going to do about this? Well, contact layers. Silicone dressings. Silicone dressings, guys, is hot right now. We're seeing silicone everywhere on all different types of wounds. We're seeing silicone bordered dressings, silicone tape. This is a contact layer made out of silicone, very flexible type product. Some people use them on skin tears. Mepitel 1, Restore, those are some just different brand names. As you see in the bottom right, they actually cut the size of the contact layer to fit the wound. They also used it on the stump. So they put that on the stump, and they're actually putting foam right on top of that, because that way the foam, they must have exudate, so the foam can actually draw some of the exudate up in the foam piece. But the contact layer being against the skin like that is very skin and wound friendly, so you can easily peel this off without much effort. It won't hurt the skin. So I see a lot of the silicone type dressings being used because it's great for those pickers in the world. You know what those pickers are, right? It's like you put a dressing on and the patient wants to pick it up and peek, or staff members want to pick it up and peek. Well, if you have a silicone bordered dressing, okay, let's say, you can pick it up 50 times, 100 times off the patient's skin a day, and it's not going to strip that epidermis off. It's very skin and wound friendly. So just kind of keep that in mind. When you know that the patient has high bioburden in the wound, definitely go into, forget the whole normal saline, get into commercial cleansers. You need to bring the big guns in. And you need to make sure that that cleanser has a surfactant in it. And what a surfactant does for you is it actually can lift the debris up easy, so when you can just wipe it clean. That's what surfactants do. Get rid of the debris. We'll use it for bioburden. Even if we suspect bioburden, we suspect it, we got a high-risk wound, just get into these. This will actually be able to bring this count down much faster than normal saline would. Now, when would we use systemic antibiotics? Okay, we'll use systemic antibiotics for systemic infection. So what that means is you have infection, but now it's jumped outside the wound margin. It's in that peri-wound space. And, so this is where we got to bring the big boys in. And there's different ones out there, IV, oral antibiotics. We would definitely pull these in if we have any patient that has osteocellulitis, sepsis, positive blood cultures. If we have a patient's wound that is affected by multiple organisms, well, we can consider using broad, like broad antimicrobial coverage from dressings. So, for instance, Silver dressings. Maybe you're not sure what the organism is, but you put the silver in place, it's going to knock it across the board no matter what bug it is. Similar to medical grade honey dressings. So these are just different types of treatments that are out there that you can use to bring down that bacterial load. So let's start from the left, move to the right. So you have Medi-Honey, and as you see the little picture there, it's a 2x2 piece of alginate, so it's Medi-Honey Special Honey that's embedded into the alginate. So it's going to keep the wound moist, okay, because we want it moist so it heals 2 times faster. And it also has that antimicrobial scent that it plays, but it also has the alginate that can help with exudate. And this will, you can keep it in place and extend your wear time. Silverline's just another product, and it is just silver, and it has a high percentage of silver in there just to knock it dead right away. And that one is good because you can actually just put it under tap water. As long as you keep it moist, put it on the wound, and it can, the same piece can be reused for up to 7 days. And then Smith & Nephew also has their own silver foam as well, and that is called Acticoat. Another product to extend your wear time. Here's just some other products out there that will help you with bioburden. We have Hydrothera Blue, and that has methylene blue in it. We also have Me Salt, that is sodium chloride. And then we also have a product called IotaFlex. See that in the bottom right? Looks like clay-like color. The mesh pieces, you would peel those off, and then you would just deposit the clay-like material into the wet wound bed. And that can be on for an extended period of time. And this is the one that has evidence-based backing it that it can actually disrupt the matrix of a biofilm. That's the only one out there that can do that. So what does that mean? 60% of the wounds you guys deal with right now are chronic wounds. They're hanging around in your buildings. 60% of them have biofilm. Not many people realize it. Well, this might be a product that you want to put in place and let it roll for 2 weeks. Use it for 2 weeks. See if you can disrupt that biofilm, and then you can follow it up maybe with a silver or a Hydrothera Blue for a couple weeks just to make sure we can get rid of that biofilm. It's just a thought. That also comes in not only the clay-like material, but also comes in a tube. So just keep that in mind, depending on how you need that delivered. Hypergranulation tissue. Well, ladies and gentlemen, that wound that you see on the screen can stay like that for 20 years, never heal because that one assessment finding, you just found it to have hypergranulation tissue. See that granulation tissue? It has mushroomed up high, and it's riding high above the wound edge. And it thinks it's healed, and it's never going to heal. So what can we do about it? We got to change this whole playing field here. We can use silver nitrate. That's what you see in these long matchsticks. That's what that is. Make sure you can do it under your license before you start picking these up. You can also use sharp debridement if you can under your license, or you can just use a foam dressing and maybe you just wrap some mild compression on top. Slowly the foam dressing will move that granulation tissue down to where it's more flush to the wound edge, and then it can epithelialize over. So that's what we would do with hypergranulation tissue. Epithelial tissue, actually, sorry, it's not epithelial tissue, it's epithely. Epithely just means, it's a fancy word for those wound edges that are curled under and rolled under. Another situation that we can run up against where that wound can stay like that for 20 years, never heal, because it has epithely. So what we have to do in this case is we could use the silver nitrate like we talked about. We can get a scalpel and we can do some surgical debridement. And we can also take gauze on our gloved finger, wrap it around tightly around our finger, and we can scrub that wound edge. Our goal is to traumatize it, make it start to bleed, and then that way it believes that it's a wound again, and it can go through the phases of wound healing. If the wound has high exudate, a lot of times it's going to throw odor off. So if you have a wound that has a lot of odor, well, number one, let's try to get rid of this necrotic tissue because that's where the odor's, sitting in. But you can use silver dressings. You could use antiseptics. Dakins, you've heard of Dakins, right? Okay. It's an option. It's actually, you have to do it several times a day in order for it to work, but it's certainly an option. Or you can use dressings that you see on the right, Carboflex, Odor, Absorbative dressing that has charcoal built into it. Yeah, charcoal. And so they come in all different shapes and sizes, and it acts as a filter to help with odor. You can also apply an ostomy or wound collector device that's right on top of it, the site, to contain the odor. Or you can use the this topical gel that you see in the bottom right corner. And this is, we all know what Flagyl is, right? So it's Flagyl cut with hydrogel. And you get this from pharmacy. You use it once or twice a day. You take a tongue blade and just put it into the wound bed, and you can put any kind of filler on top of it if you have dead space. But do that, and that's very effective against odor. Speaking of that, I don't know, do you guys see these orders where they want you to take 2 Flagyl tablets and crush, crush, crush and sprinkle it into a wound? Okay. That's old-timey, and we're really not supposed to do that. This is the product we got to use, and they actually found in the studies that this is actually less expensive. When we were crushing tablets and stuff like that, that is actually beyond the scope of, let's say, a nurse, because that's compounding, and we're not supposed to do that. So use this instead of the crushing the pills and sprinkling it in. We don't know. I mean, that's like an oral pill. We might overdose that wound and have adverse reactions, and we don't want to go there. If we have moisture-related skin breakdown, well, these are some different products that we can use, which is a lot of times very sophisticated type barrier creams that are created to last on the skin for an extended period of time. So calmiceptine, Triad. The beauty of Triad, guys, is it is good for partial thickness wounds and also full thickness wounds. And you just, frost the area like a cake, put a nice layer right on, and you don't even need to put a dressing in place. When we have an intact healed blister, we do not want to poke a hole in it, okay, right? We don't want to do that. Because we poke a hole in it, then the bacteria are going to move right in, and we don't want that to happen. And then plus it could cause pain to the patient. This is nature's Band-Aid, so let's just protect it, offload it, and if it's going to pop, let it do it on its own, but we don't want to prematurely pop this. Slow healing wounds, well, this is where we're going to pull in the biggest dog, okay, and that's going to be collagen. And our body makes collagen, but sometimes the wounds forget to make collagen because they've been hanging around for so long. So by us using any one of these products on the screen, we put it into the wound bed, it actually stimulates the body to create more collagen, you're going to have more granulation tissue, and it's going to just start to accelerate. So collagen, out of all the categories out there, is backed up by the most evidence-based research, and that's collagen. So if collagen is like usually an afterthought, I want you to bring it up to your top 3 considerations. You have wounds that are hanging around for a while, go to collagen. It's got to be a clean wound in order to use this stuff, okay? Choose the right dressing to suit the conditions is vital for optimal healing and quality of life. See this little dog? So, make sure you are considering those things before you even pick up a wound, all those different things that we talked about, the wound location, the size, and so on. And make sure that the dressing that you're choosing is going to complement that patient's life. This dressing that they put on this dog is not complementing his life. He now only has 3 legs, and he can't hear because they put this big, bulky dressing on his ears. Not good. Before you leave, let me give you some instructions because I know many of you on the line right now want continuing ed. So what's going to happen is you're going to get an email from me, WCI. It's going to look like this. And you're going to get this by June 26th, if not sooner. And what I want you to do is click the hyperlink, do the evaluation for today's webinar. Once you do that and it submits to us, then your next email from us is going to be your continuing education certificate. And if you do not see this, I want you to check your spam folder because a lot of times we'll go right into your spam folder. For those of you that are sitting in groups, download the sign-in sheet, the evaluation form, complete it, and fax to Wound Care Education Institute at our fax number there. Give us 7 days. Once we get all the pieces from you, we'll make sure we have them and we'll release the CEs to you within a week. Those of your coworkers that might have missed this recorded version, we are going to have this on our website faster than 3 weeks. We're going to have it by Monday. How's that? That way you can let your friends know and you can share this webinar. Well, I want to say and give love to Shield Healthcare for making this happen. I appreciate the time and coordination of this. John, thank you. I'm going to pass this on to you.
All right. Thanks, Nancy. That was a fantastic presentation. Lots of great information jammed into 59 minutes. So really impressive how quickly you got through that. I certainly learned a lot, as always, so we really appreciate it. As Nancy mentioned, This webinar has been recorded, so if you miss anything, you can come back and watch it both on our site as well as WCEI. There were a few questions that came in, like will the slides be available? Again, the slides, we can't make these slides available as they're proprietary to WCEI, but you can feel free and re-watch the wonderful presentation again and again and again. And so you'll always remember some recommended treatments. I'd like to thank everyone who attended this webinar. This was super informative. Again, thank you, Nancy, for this great information. This information will be posted to our respective sites. And again, if you have any questions, please feel free to email us at marketing@shieldhealthcare.com. So once again, thank you for attending, and we look forward to seeing you all again at our next webinar in July. Have a great day, everybody.